Nikki, in traditional medical schools curriculum, we have usually have major basic science blocks. So students may go through weeks of biochemistry, weeks of physiology, weeks of anatomy. Many medical schools, including ours, have changed it to more integrated formats. That means physiologies won't be taught in a bolus structure at the beginning of the year or the beginning of the medical school, but it's going to be sprinkled all along the curriculum. So some people may think that, how do we make sure that we have enough attention to basic science, deliberate attention to basic science? How do we make sure that students actually get it when we mix it up with clinical context or mix it with other psychosocial issues? What do you think about that?
So this is a standard problem that any contemporary medical school is trying to solve. Historically, yes, we've wanted our basic sciences to form that kind of introductory core to medicine. You have to learn and you have to spend a great deal of time immersed in these fundamental basic sciences before you can proceed to the real stuff of being a physician and move on to your clinical sciences. The challenge with that kind of 2+2 model is it reinforces the idea that the basic sciences are valuable in isolation, and that students can learn isolated concepts from any of the basic sciences, and then they're expected to spontaneously transfer that knowledge to the clinical context later on. What we've seen in the laboratory and in other studies, what we've seen over and over again is that this idea of spontaneous transfer just doesn't happen. When students learn things as isolated concepts, they use them as isolated concepts. And that means that when they actually need to have their basic science knowledge to solve a clinical problem, they won't be able to do so. Instead, what we want is for students to actually develop what we call a semantic network of content. A semantic network essentially means that we want students to develop a mental model that includes both basic science concepts and clinical science concepts in a coherent, tightly knit form. So a semantic network isn't something new. It's essentially something that we've adapted from cognitive psychology. And really what it means is that the mental model for any type of content is made up of an elaborate set of abstract concepts and specific experiences in memory. For our students, what we want them to be developing is a network that includes the signs and symptoms of disease and the basic science principles that help to hold those signs and symptoms into a coherent network. As the student gains experience, that network will grow. And so by choosing to adopt a model of education that allows students to practice and engage in material in an integrated fashion, we're hoping it'll be easier for them to develop an integrated semantic network.
So I have a question about application. You mentioned about the evidence behind it, but how do we apply those evidence or this theory into the development of our new curriculum? So specifically, I'm wondering if you have any tips for our curriculum developer and also tips for our CBL tutors, or case-based learning tutors, when they actually deliver a case with a group of students.
So the key thing with the semantic network is that it contains two components. The nodes of the network, which are the core concepts that we want the students to learn, which in our case would be the clinical concepts, and the connectors, which in our case would be the basic science explanations. One of the important things for teachers to remember is that all of the power in a semantic network is in the connections. It's the most important part. Without the connections, the whole thing falls to pieces and you end up with an unorganized network or a bunch of isolated nodes that just aren't going to work together. For the teachers, it's important to realize that even though the nodes and connectors, or the connectors specifically, are the most important, they're the toughest to see. So it's the job of the teacher in CBL, it's the job of the people responsible for designing the cases and actually helping the students work through the problems to help the students recognize and explicitly see the connections to their basic science content. Left to their own devices, the students will not pick up on those connections on their own. So it's the job of the instructors to guide the students toward actually seeing what are the connections, what are the whys. Why is the science useful here? What is the underlying mechanism here that's explaining the symptoms in the case? It's really the responsibility of those responsible for designing the curriculum and implementing the cases to help the students see the connections and to make the connections between the clinical content and the basic science manifestations explicit.
So a curriculum developer will have to pay attention to how the lectures and other activities are sequenced, and how we combine both basic science and clinical concepts together. Whereas the CBL tutors would also have to challenge our students, their understanding. So even if they can recite the management and the drugs and the symptoms, but if they don't really understand the basic science behind it, then they may not be able to transfer their understanding to another clinical context or problem.
Yeah, that's correct. So I think that the general tendency for students and sometimes for teachers is to focus on the clinical, to focus on the signs and symptoms, focus on how the students understood the patient. And of course, that's very important. But what's really key here is helping the students see that deeper level. We want them to understand the deeper structure of the problem, not just the surface level description. So the extent to which those who are responsible for the curriculum design and those who are responsible for the delivery can actually reinforce that understanding of deeper structure, that will help us make sure that the students can then use that deeper structure to build new knowledge and solve future problems.
So that makes perfect sense. I think one thing to add is that when we are developing assessment questions, this is something that we have to keep in mind as well. Is that right?
Yeah, definitely. So one of the most important roles of assessment in terms of assessment driving learning is that we can use the opportunity when we're actually having the students take a test to reinforce this idea of understanding the underlying connections. So we want to make sure that our test questions actually do this by testing the questions. So the objective when you're creating a test needs to be to reinforce, yes, the basic science concepts. Yes, we want to test the understanding of the clinical content, but we also want to make sure that we have questions that explicitly require the student to explain the mechanism, explain the why. And we want to make sure that we're creating test questions that assess what really is important to us, which is this cognitive integration of basic and clinical sciences.
Okay. Can you elaborate a bit on cognitive integration? What does it mean?
So cognitive integration is a construct that we've been talking a lot about here at U of T. And essentially what we mean by this is we want to look at integration as an activity. It's an activity that occurs within our learners and not something that just exists on our curriculum plan. Cognitive integration really means the active connection of basic science content and clinical content in the minds of our learners. So it really is an activity. It's something that we want to encourage our students to do. It's something we want to model for them as instructors, and it's also something we want to test. And it really focuses on this idea of understanding how these two pieces of information go together and fit within a tightly coherent network of understanding.
Great. Thank you very much, Nikki.
You're welcome.